Assalamu alaikum. I hope you all are okay and fine. Today we are going to discuss a really important topic about the laparoscopy, the minimal access surgery, and complications of minimal access surgery. And complications can happen at any surgery. So one must be ready for it, and one must know how to prevent those complications. Today's lecture will be focusing upon one branch of the complications of laparoscopic surgery, and that component is the mainstay of laparoscopic complications, which is the vascular complications in laparoscopy. So we are going to discuss how these vascular complications occur, what are the causes, what are the important steps where you can prevent those complications, because prevention is always and always better than cure. And once a complication happens, it's really difficult to handle it, especially if the complications are in a major vessel like the inferior vena cava or the aorta, or for that matter, common iliac or external iliac vessels. So bleeding is one of the most dreadful complication of laparoscopic surgery. The mortality of bleeding can reach up to 13%. So imagine if you prevent this bleeding from occurring, you will be preventing a 13% mortality. If it is not controlled, it can lead to a disaster. So the management is the general management is, number one, you have to call for help, and the help may be that of the vascular surgeon, or that may be an experienced surgeon, a surgeon who is senior to you, or one of your colleague who is busy around the corner in the next operation theater. He should be called. And a second assistant, you will always need a second assistant. The first assistant is holding the camera, and he's helping you around with the traction and retraction and the suction. But you may need another assistant, and the anesthesiologist must be taken on board, because once these complications happen, the vascular complications especially, you may be increasing the pressure to the dangerous levels in order to temporarily control the bleeding. And in that period, the anesthetist must be standing with the patient so that he can manage the physiological and the pathophysiological impacts of bleeding, as well as the increased pneumoperitoneum. And the equipment must be there, the vascular clamps, the suction can be of 5 millimeter a diameter or 10 millimeter. So you must have all those equipment ready. And as I already mentioned, that prevention is the best cure. So, and prevention is better than even cure. For a beginner, it is must that he or she, in the first learning curve of the laparoscopic career, he or she must go for an open technique. Majority of vascular complications, especially those of the major vessels like inferior vena cava and aorta, they happen during the first trocar placement. So because this first trocar is always blindly placed, you don't know what is the anatomy inside the abdomen, where is the liver, where is the spleen, where is the stomach, where is the gut, is it distended or not, one doesn't know. So the first trocar placement usually leads to the vascular complications. However, the vascular complications can also happen while traction, retraction, the dissection, using an energy source. So the advice would be for the beginner that in initial part of their career, they must be using an open technique for the placement of the of the first trocar. Once the first trocar is placed under vision and the pneumoperitoneum is created, you can place a telescope into that that trocar, that port, and this will lead to a visualization of the peritoneum from the inside, and then you can place the other ports under vision in order to prevent the complications. This first trocar placement can be a 5 millimeter. If you place it, like for example, in a right-sided nephrectomy, you place it in the right iliac fossa and you create pneumoperitoneum. The port is 5 millimeters, so you bring in a 5 millimeter telescope. The vision will not be good, but at least it will be better than a blind procedure. So if you are placing the first port without any vision, then it has to be away from the midline in order to prevent major vessel complications. However, in cases of grossly hydronephrotic kidneys, huge renal tumors, this first trocar can go into the tumor or into the kidney, which can make things messy. So even placement of trocar away from the midline can also be a very tricky thing. So these are the steps of management. We will be repeating these steps again and again in the coming presentation, because these are the basic sketch of the management of such complications. Like, you call for help, you increase the pneumoperitoneum, you inform the anesthetist, and you call for another assistant to come. Even if he or she is not available, the second assistant, you can place a camera holder for you. So the steps of management will be repeated again and again. As I said, top of the line management is the immediate attention. I mean, it shouldn't be that there is bleeding and you are keeping on with your procedure, and in the meanwhile the patient is losing a lot of blood pressure, a lot of blood, and becomes hemodynamically unstable. So in face of pneumoperitoneum, it will be difficult for the anesthetist to control the situation then. So immediate attention must be paid to any bleed, because there is pneumoperitoneum. If there is even a small bleeder, due to that pneumoperitoneum, the bleeder may not be obvious. So once you are done with the procedure and you remove all the gas from the abdomen and you come out, and then you see that there is a lot of drain coming, or the abdomen has gone distended, or the patient has become hemodynamically unstable. So that is because that bleeder, which did not seem to be really major during pneumoperitoneum, because of the pressure on that vessel, that has now become a major vessel, because a major bleeder, because pneumoperitoneum, or the pressing effect of the pneumoperitoneum, is relieved. So immediate attention must be paid to every bleeder in laparoscopic surgery. The instruments are already inside. You do not really rush to have to place the instrument inside. The instruments are there, and of course, in one hand you must be having a non-traumatic forceps, and you can just get in a gauze piece, or you can get in another atraumatic forceps to grab that place where it is bleeding, and then you take suction and remove all the red clots and blood from the field. It will make your vision better, because red color, it absorbs all the light. So if there is less red color, the vision will be better, and you'll be in a position to deal with the bleeding. So there is a temporary control of the bleeding, and then there is a definitive control. This temporary control again has the same steps. You immediately compress the vessel, either by your instrument, or by a gauze piece inside, or a suction device. or atraumatic forceps. There is no suturing, there is no clamping. You just have to compress the bleeder, and this is the principle of any hemorrhage. It's a general principle. So you press it against another surface, and one hand should always be free and ready to deal with such situations. So by these way, you can do a temporization of the bleeding or temporary control. In the meanwhile, you need to have a suspension. Like, for example, if you want to suspend the colon, or you want to suspend the renal pelvis, so you bring in a suture from the outside, and you take that tissue into that suture, and then you bring the needle outside, and then you can suspend it from the outside with an artery forceps, or a assistant can hold it for you. Camera holders are usually available if your cameraman is an experienced surgeon, and you need another hand because one hand is always kept busy by the camera. So you must have a camera holder, so that the camera can be held by the camera holder, and the second hand of the assistant is available for you. Additional trocar is at times needed. It should always be kept in mind that the placing another trocar, whether that is a 5 millimeter or a 10 millimeter, does not pose any significant difference to your procedure. It is just a small half centimeter or 1 centimeter incision. So just place it. It will always be helpful, because at times your trocar is at such an angle that you cannot clip the vessel, or you cannot use a staple device. So then you have to have another port. The second additional port may also be required for an additional assistant, so that he can hold and retract the tissue for you, or it can also be used for a suction device. So always temporize and temporarily control the bleeding first, and then think about the definitive management. Sorry. Prevention is better than cure. So in face of vascular complications, it is really important that one must know the dangerous steps where the bleeding can happen. Like I said that the bleeding can happen while placing the first trocar. So if you are really careless placing the first trocar, so this can happen. So by placing the first trocar or port, if you go by open technique, it is already prevented. And then you must know what are the locations. Like, for example, in this CT scan, you see how much hydronephrotic is the kidney, how much is it distended, is it touching the anterior abdominal wall. So if then you are placing a port even away from the midline, you may go into the kidney and cause bleeding, or you may go into the renal hilum. So in that case, dangerous steps and dangerous locations must be identified. In that case, if there is gross hydronephrotic kidney, you can go through the iliac fossa. So dangerous steps need to be identified. On the right side, doing the nephrectomy, you must know that the renal vein is really short. So while dissecting the renal vein, one must be really careful, because the angle of the renal vein with the inferior vena cava, this angle can get injured while dissecting the renal vein. So that can be of can be a really cumbersome situation, because it is in the angle. Then you can just hold it, but you can't apply a clip, you can't apply a stapling device, and of course you have to repair it. So that is a dangerous location. Another important thing is the superior mesenteric artery. In case of left radical or simple nephrectomy, the mesenteric artery is going horizontally and crossing the anterior surface of the renal vein. So while dissecting that area, if you are going medial to the gonadal vein, and especially the the adrenal vein, then you must be really very careful, because that is the location where superior mesenteric artery will be. So identification of the danger steps and location, it must be there in your mind if you are wanting to prevent the complications. One hand should always be free for a response. An atraumatic forceps must always be kept on the field, like for the right-handed surgeon, the left-handed port and the left-handed working port must be having an atraumatic forceps. I usually use an atraumatic bipolar forceps. It is really helpful in retraction. It can be used as a bipolar diathermy, and it is so fine that it can be used for dissection as well. You can see that in my videos. So one atraumatic forceps must always be on the field, so that if there is injury to the vessel, it should be immediately grabbed with that vessel, because if you are grabbing it with a traumatic forceps, the injury may increase and the problems will increase definitely. No one-handed dissection is recommended. Dissection must always be two-handed, because it is the laparoscopy is all about ergonomics and hand-eye coordination. So if one person is retracting for you and you are doing dissection with one hand, that is not really going to work, because you don't know how much is he retracting. Is he retracting more than it is required? Because such retraction may lead to avulsion of the veins and small tributaries of the veins. So two-handed dissection must be performed. Suction should always be inside, so that if anything like that happens, the blood will be collecting there. So suction has to be there to remove all that blood, to visualize the area from where the blood is coming, and secondly, to improve the vision as well. Okay. So what are the potential vascular injuries? The potential vascular injuries in urologic surgery are injury to the renal vein, to the renal artery, inferior vena cava, aorta, iliac vessels, and superior mesenteric artery. So the general principles of any hemorrhage during the surgery must be followed in laparoscopy as well. Like, for example, you must know, does the patient need a transfusion? If the patient needs a transfusion, you must immediately inform the anesthetist to cross-match the blood so that it is available before there is hemodynamic instability. Let's say, for example, you have tried and you are not able to control that bleed, and you want to convert the patient immediately, you want to open it, even then the transfusion is required, because if during the phase of pneumoperitoneum, the bleeding is very less as compared to when you will be opening it and suddenly the pneumoperitoneum will be released and there will be sudden gush of blood, and for that you must have blood or blood products. Do you really need to go on, or do you want to convert it? So the indications of conversion will be discussed later, and anesthetist must be communicated with. If you are increasing the pneumoperitoneum from 12 to 18 or 20, there are going to be significant hemodynamic effects of pneumoperitoneum. So those need to be controlled, and for that anesthetist is a must. So do you need help, or you want to continue alone? So it is always better to get help from your colleague, from your junior, from your senior, or the vascular surgeon. And tools and instruments must be ready when such complication happens and you are dealing with it laparoscopically. Even then, the trolley must be present. It should not be present in the sterilization department. It should not be present in the room next door to the OT. No, it has to be open. And all the instrument, including the retractors, the vascular clamps, the suction device, the open diathermy tools, all have to be present in the room, and the scrub nurse has to be present there. And another principle which is a general principle during any kind of complications in a surgery, is that you should not panic, because if you are panicking, the anesthetist is going to get panicked, your team is going to get panicked, the one you are calling for help is going to get panicked, and the panic situation can lead to worsening of the scenario rather than controlling it. And then after all these measures, you have decided that, okay, I want to continue, then you have to temporize the bleeder or temporarily control that bleeding. That can be done by clamps, like I mentioned, that can be vascular clamps, or that can be non-traumatic graspers, and you just need to compress that bleeder. You just have to press it. If you cannot hold it, press it with a gauze or laparoscopic instrument for that matter. And you can also increase the pneumoperitoneum. And you must identify the site and source of bleeding, whether this is a major vessel, whether it is IVC, or is it a right renal vein, or is it the junction of the or the angle of the renal vein and IVC, because it is going to be a different management for that. Is it the avulsion of the gonadal vein from the inferior vena cava, or is it a partial avulsion, or is it a complete avulsion? And for that, you need to identify whether this is a venous bleed, whether this is an arterial bleed, or the kidney is bleeding. So the site of bleed, source of bleed is going to decide the further management of the complication. If it is aorta, just grab that site and immediately convert the patient. If IVC, if you have an experienced hand, you can repair. If the tear is small, the hole is small, you can repair it. Then okay, you can repair it. Otherwise, you have to convert. So identification of the site, and for that you need to clean that area with a suction, and then you will be able to see what is it that is bleeding. So these are the general principles. Okay. Pneumoperitoneum can control and temporize the bleed, but it cannot be done for arterial, because the arterial wall is thick. It has got a thick muscularis layer, so it cannot be compressed by the gas. Yes, of course, you can compress it with a gauze or with an instrument, or you can grab it with a forceps, but it cannot be compressed by the pneumoperitoneum. So pneumoperitoneum increase is not for the arterial bleed, it will be for the venous bleed. And if you are applying suction continuously, and for that matter it is a 10 millimeter suction, then the increase in the pneumoperitoneum is not going to work, because the same amount of gas which is coming in is going out, or even the amount which is going out is even greater than what gas is coming. So continuous suction will not allow an increase in the pneumoperitoneum, and you must keep that in mind. So and it doesn't work if there is any gas leak. It happens. That's why I said that you must not get panicked, because if you get panicked, there may be leaks. The assistant may be using the suction continuously. The vision is going to get worse and worse, and things are going to get, and scenario is going to get worse as well. And by increasing the gas, there are two major complications. Number one is the risk of gas embolism. So you must inform the anesthetist that I'm going to increase the gas from 12 to 18 or 12 to 20. So this increases the risk of gas embolism by 4-fold. So anesthetist must be informed. And another important thing is the hypothermia. So that must be kept in mind. After taking the temporary control, you have grabbed that vessel. You don't know what is it, but you have grabbed it, and there is no bleed now. Or you have compressed it, or the pneumoperitoneum is increased and the bleed has been controlled. Now take a deep breath and relax and stop panicking. Clean the area with the suction, and while doing that, you think in your mind what you are going to do. Are you going to continue with the minimal access, or are you going to convert it? So that should be the, if you are going to continue, you must call for help, the vascular surgeon, a senior colleague, or an experienced colleague in laparoscopy. And also you must prepare for conversion as well. So in the radical nephrectomy, on the right side and the left side, the vascular injuries may be different. On the right side, the inferior vena cava, the right renal vein, and the gonadal vein, and even the adrenal vein may be a source of bleed. But on the left side, the left renal vein, the aorta, the superior mesenteric artery, and the lumbar vein may be the cause for the bleed. So that needs to be kept in mind. The area where you are working below the renal hilum on the right side. So it can be a renal vein or IVC junction, or it can be a gonadal vein as well. Or there are at times accessory vessels which need to be discerned and need to be seen in the CT preoperatively, and those need to be kept in mind while dissecting all those vessels. The artery is at times superior. Most of the time it is in the posterior inferior location of the renal vein, and can be in totally posterior location. But the difficult part is that when the renal artery is superior to the renal vein, so the injuries to the renal vein may happen. Coming to the injury of the inferior vena cava, of course it is a venous structure, so you need to increase the gas pressure from 18 to from 12 to 16 to 18 or even 20, and you can press and hold that the injured site and temporize the bleed, and then you can decide whether you want to repair it or you want to convert it. Of course, you have to place more ports in order to be ergonomically possible for you to repair and apply the sutures. Intracorporeal repair for highly expert surgeon. However, if you are not really experienced in suturing, and especially in managing the sutures of the vascular structures, you must think of involving a senior colleague, or you must think of converting it, and cross control all the IVC with the bulldog. So if there is a linear tear, for example, you have to take control of the inferior vena cava below the injured site and above the injured site. The opposite, like for example the left renal vein, in order to decrease the hemorrhage. So once the hemorrhage is controlled, you will be able to apply the sutures. But if you are not really comfortable with it, the bleed is more, you suspect that there will be hemodynamic instability, then you of course have to convert the procedure. Aortic injuries are really very rare, but there is complete loss of anatomy because there is dissection under pressure. So you need to convert it immediately, and you must involve a vascular surgeon, and at times grafts are really needed to repair those injuries of the aorta. Okay, renal vein injury, left or right side. You must identify whether this is like on the right-sided video, you are seeing that we cannot see, even the clamping cannot reduce the bleed, and then I had to take a longer clamp to clamp that. So I have temporized it, I have cleaned the area, and then I'll see what is the area of the injury. So I placed another port, and that led to placement of the clips and control of the bleed. So you must identify whether it is the renal vein, or is it the IVC, or the angle. As I mentioned, the angle needs to be stitched, and the pressure needs to be increased to 20. You maintain the anterior traction of the kidney, and then you of course apply the clip or a staple device to control the vein, and then you need to even decide to convert. On the left side, you can see that the bleeding is controlled by compression with the gauze piece for 5 minutes. It is nicely controlled, and then we managed it. Renal artery can occur during the dissection of the renal artery. Most likely it is from the surrounding lumbar vein rather than the renal artery, and you can increase the pressure. If at all the renal artery you cannot control, then you have to increase the pressure, or you have to even apply a bipolar forceps and clip and staple, and then you may decide to even convert. On the right-sided video, you can see that the clip is attached to the gonadal vein. It's a very dangerous maneuver. It can by pulling the vein, we can avulse it from the inferior vena cava. While on the right hand side, you can see that there was a tear in the renal vein, which was controlled by compression and then by applying a hemolog clip, and then we went on for the artery. So it is really important in the management of the renal vein that the renal artery must be first dissected enough and clipped, because if you apply one clip, then the venous bleed, even if it occurs, it will not be really major. So you can manage it with a minimal invasive technique. If the artery is not clipped and the vein is injured, then of course at times it is difficult to control the hemorrhage. When to convert? It's really very simple. Hemodynamically, patient has become unstable. The anesthetist will tell you that the blood pressure is going down, this patient is tachycardic, the pulses are feeble, so you go for conversion. And of course, during the conversion, you must not just leave everything and start opening the patient. One hand of yours or your assistant must be on that vascular structure which is bleeding, so that it is compressed so one must be holding it and you will be opening it. So conversion must be perfect. It is, if you are unable to control or reach the bleeding source, then of course just compress it and you open it. And if there is inadequate visualization, so where is this bleeding coming from? Is it coming from a viscera, from a kidney, from a vein, or an artery? Or if there is difficult angle for suturing or stapling, which can be overcome by placing another port in line, which will help you placing the staple device or the suture, or for that matter a clip. And if you are inexperienced in suturing and controlling the disasters, then you must convert. Here you can see on the right-handed video that we have completely mobilized the kidney. We have we did everything, but the last clip that we applied, it went through the renal artery, and so we immediately converted it. And on the left-sided video, we saw that the vision was not adequate. I mean, we could not differentiate where is the vein, where is the artery. So instead of creating a mess and then converted it, so we decided to convert it before anything bad happened. So that is called the prevention of the hemorrhage and the vascular complication. One must not be overconfident, but one must not be underconfident as well. A surgeon must always know his or her limitation. Once you know your limitation, you will never harm the patient. So before converting, as I mentioned in the previous slide as well, you must temporize the bleeding site, because if you are not temporizing it, there is a pneumoperitoneum 12 or 14 or 16, and you immediately open, and that suddenly pneumoperitoneum is released, that will lead to sudden gush of blood. So that we need to prevent. So before conversion, you must temporize the bleeding, and you make sure all the necessary open tools are available, the assistants are available, they are ready, they are having suction in their hands, the The overhead lights are open, the OTAs are available, your surgeon is available, vascular clamps are available, and for that matter, at times the vascular surgeon is available. So then you should convert. Okay. The superior mesenteric artery, it is a site of injury or bleed or hemorrhage in left-sided nephrectomy, left-sided procedure. So it happens usually in the transperitoneal approach. In retroperitoneal, it is away from the surgeon, so it is really not in danger. But in transperitoneal, one must be aware of the locations of superior mesenteric artery. So at times it is misjudged for a renal artery because it may be taking a curved course anterior to the renal vein, and the surgeon is happy and just clips it. So that is one thing, and it must be taken into consideration that the artery, if it is coming, it must pierce the Gerota's fascia in order to be a renal artery, and it must enter the pararenal space rather than going again medially. So that has to be kept in mind, and the renal vein must be taken as a reference. It is almost always crossing anterior to the renal vein in a horizontal fashion, but at times, as I said, it can take a curved course and then turns back towards the peritoneum. Here is where the problem occurs, and so it must be, if you are suspicious that I already clipped a major artery, why is another major artery coming to the kidney? Then it must be a superior mesenteric artery. And if you are suspicious that the artery is coming anterior to the vein into the kidney, then you must be suspicious, and then it has to be followed towards the Gerota's fascia. So as mentioned in the previous slide, an artery which is anterior to the renal vein must be a superior mesenteric artery unless and until proved otherwise. An artery which is in an atypical orientation, because the renal artery will usually be in a vertical position or a vertico-horizontal position, but it must always be piercing the pararenal space, Gerota's fascia, and coming into the kidney. So you must follow where is it going. And an artery which is medial to the aorta can be a superior mesenteric artery, because renal artery arises from the lateral surface. And all these must be seen in the preoperative CT scan evaluation. So the iliac vessels, like common iliac vessels or the external iliac vessels, get injured while doing the pelvic lymph node dissection, or doing, for that matter, ureteric reimplantation, or for that matter, performing orchidectomy for an undescended testes. So these can be injured, and a cross clamp is usually required, and they can be easily repaired with Prolene. However, if you are not experienced, you must look for an assistant or experienced surgeon who can handle it, or you can convert it as well. Then another peculiar condition is the bleeding during nephron sparing surgery. It happens when you are cutting the tumor. So if you have not properly clamped the artery and the vein, it will happen. Or you have missed an artery. For example, there is an early branch from the renal artery, and you have dissected distal to that branch and clipped that branch. So one small branch will be remaining, and that will lead to the bleeding. So it has to be looked for, the early branching. There may be an ectopic artery which may lead to branch, and look for that branch that you have left. Can you handle it with a minimal access? Do you have the capability? If you have the capability, you must control it, and you must keep on continuing doing the nephrectomy. Not that half tumor is cut and half there is bleeding, and then you are trying to control the bleed. You must go and continue with the cutting the tumor. Once you remove the tumor, all the bed of the tumor will be in your front, and you can see where is it bleeding from. You can bipolar it, you can apply pressure, you can also use various devices for that. You can go on and and clamp the artery and the vein. If you have clamped only the artery, you have left the vein, then you go on and clamp the vein as well, because at times it is a backflow of the vein. So it can easily be controlled with a minimal access surgery, but you need to have a good suturing skills. As they say that there is no future without suture. So suturing must be practiced to perfection, because suturing is going to help you a lot in minimal access surgery while dealing with all these complications. Your assistants in nephron sparing surgery has to be really vigilant and has to be an relatively experienced surgeon as compared to other procedures, because he will help you clean that area for you, clean the plane of cutting for you. He will also be retracting the tumor for you. He will be retracting the renal bed also. So because dissection is always about the traction and retraction, so he or she has to be an relatively experienced surgeon. So another episode of such bleed can happen after unclamping. So you need to unclamp it early to see where there is any bleed or not. Because once you suture all the bed and then you unclamp it and then it bleeds, it will be difficult for you to locate that bleeder. So once you remove the tumor, you should unclamp it and then clamp it to see where the bleeder is, or to see really if there is any chance of bleed or not. And then you suture the bleeder. You can very easily reclamp the vessel and do the procedure. So the conclusion is, you must leave your ego outside the operating theater, and you should be really vigilant in the patient selection. Patients with small abdomens, really very thin, they are more prone to develop complications, especially the vascular complications of the first port. And the second thing is that you should not hesitate to convert. Remember, conversion in minimal access surgery, it is not a failure. You must always seek help of an experienced surgeon, help of a visceral surgeon, help of a vascular surgeon, and you must always take into consideration the help of a second assistant. So these are the conclusions of the presentation. And really, I would say that prevention is always better than cure. And if you really prevent by doing a proper selection of the patient, you'll be really in good position. So the take-home message is, step number one: if it bleeds, always temporize the bleed. Once you temporize the bleed or temporarily control the bleed, only then can you decide whether you want to deal it with the minimal access or you want to convert it. And always try to recognize the site. At times there is a small renal vein, which is a small vein of the tributary which is bleeding, and we get panic and then we open it or convert it. So always recognize the site and then decide. The exposure and must be proper by doing the suction and cleaning the area, and always your one hand must be free, and always control the bleed before conversion. Temporarily control it. And I already mentioned that conversion in laparoscopy is not considered to be a failure of laparoscopy, but it is for the safety of the patient. So always and always keep your ego away from the operation theater. Thank you very much.